Good morning, my dear students. Today I will talk about the disorders of the adrenal glands. It's a very important chapter in MBBS. The adrenals are the endocrine glands. It consists of cortex and medulla. The medulla is an extension of the sympathetic nervous system and it secretes catecholamines, that is adrenaline, noradrenaline, dopamine. Adrenal cortex, these are actually consists of cells secreting cortisol and androgens, and they form part of the HPA axis, that is hypothalamo-pituitary adrenal axis. This is the picture of the adrenal gland. This is the right adrenal gland, this is the left adrenal gland. As you can see, it is the medulla, the inner portion, and the outer portion consists of the cortex. Here, this is the histological picture. It consists of the adrenal gland consists of the cortex and medulla, as I already told you, and further it is divided into zona glomerulosa, zona fasciculata, zona reticularis. This is the glomerulosa, this is the fasciculata, this is the reticularis. As I told you, but it actually functions as two units. One unit consists of zona glomerulosa and the next unit consists of zona fasciculata and reticularis. So basically they function as two units, the cortex. Now glucocorticoids, the most important hormone. Cortisol, the levels are the highest in the morning and lowest in the midnight. Actually there are diurnal variations in these hormonal levels. This increases during stress and illness, but most of the cortisol, as you can see 95%, is bound to cortisol binding globulin and it is affected by estrogens. So during measurement of this cortisol, estrogen should be stopped. The free form is the biologically active form. And one thing to remember is cortisol can activate the mineralocorticoid receptors, but it normally does not do so because the most cells contain these 11 beta HSD2 enzymes which converts the cortisol to the cortisol. Now the mineralocorticoids. Aldosterone, it is the most important. It binds to the kidney receptors and causes sodium retention and increased excretion of potassium and hydrogen ions. The principal stimulus is angiotensin II. And you should remember that the renin activity in the juxtaglomerular apparatus, the JG apparatus means the juxtaglomerular apparatus, it is stimulated by low perfusion pressure in the afferent arteriole, low sodium filtration or increased sympathetic activity. Renin activity is increased in hypovolemia also. As you can see from this chart, angiotensinogen, renin converts angiotensinogen to angiotensin 1, which is converted to angiotensin 2 by angiotensin converting enzyme. And angiotensin 2 then acts on the gland and secretes aldosterone. Catecholamines, the small portion of circulating norepinephrine is derived from the medulla. As I told you, it consists of epinephrine and norepinephrine. And regarding the norepinephrine, much more is released from the sympathetic nerve endings than from the medulla. Conversion of noradrenaline to adrenaline is catalyzed by COMT, that is catecholomethyltransferase. It is induced by glucocorticoids. And you should also remember that the blood flow of the adrenal glands is centripetal. Regarding the androgens, it is secreted in response to ACTH. It is important in the initiation of puberty. Also, a major source of androgens is adult females, and it is also important in female libido. Cushing syndrome, it is the most important disorder. It is caused by excessive activation of the glucocorticoid receptors. The causes are iatrogenic. Iatrogenic means administration of systemic steroids. It is the most important cause. You should think about this cause and take it properly in the history before proceeding to any other causes. The second cause is the endogenous cause. And among the endogenous causes, the most important and most common is the ACTH dependent cause. It consists of 80% of the causes. Pituitary adenoma secreting ACTH is more important, consisting of 70%. It is also known as Cushing's disease. And ectopic ACTH syndrome, it is actually a syndrome which occurs in response to certain malignancies such as bronchial carcinoid and small cell lung carcinoma, this is SCLC. Non-ACTH dependent, it consists of 20% of the cases, among which 15% are adrenal adenoma. And there is also another entity which is not very much common. It is ACTH independent macronodular hyperplasia. Other causes are alcohol excess, major depression, primary obesity, means excessive body weight, depression, alcohol excess, persons taking excess of alcohol. Clinical features. The most important thing in clinical features is that the symptoms are non-specific. You cannot specify a particular symptom to a particular cause. These are non-specific symptoms. As I told you earlier, the iatrogenic causes should be excluded by history. Iatrogenic means whether the patient is taking systemic steroids in the form of prednisolone. Inhalation steroids rarely causes this syndrome, that is iatrogenic syndrome, but you should also take history of the inhalation steroids also. But the oral steroids and systemic steroids are much more important causes. 8 to 9 hour serum cortisol levels less than 100 nanomoles per liter with normal sleep-wake pattern and Cushingoid appearance, I will tell you what it is consistent with exogenous synthetic glucocorticoid use or cyclical cortisol secretion from endogenous causes. Now, the second cause is uncommon. This is uncommon. Commoner is this one. Unlike in ACTH secreting pituitary tumors, the negative feedback sensitivity to cortisol is absent in ectopic ACTH syndrome, which has higher levels of both ACTH and cortisol than in pituitary disease, causing marked pigmentation. So you can see in ACTH secreting pituitary tumors and ectopic ACTH syndrome, the level of ACTH and cortisol differs, which can help you to differentiate between the two. And the pigmentation which occurs, it happens due to binding of melanocortin 1 receptors on the skin melanocytes. Now the classical features of ectopic ACTH syndrome, if present, less aggressive tumors like bronchial carcinoid may be the cause. And in pituitary disease, pituitary tumor is usually a microadenoma. So unless the tumor is large, you cannot get the visual field defects and hyperprolactinemia in the clinical history. And hyperprolactinemia usually causes galactoria, that is secretion of the milk. Clinical features. Clinical features are hair thinning, hirsutism, acne, plethora, psychosis, cataract, mild exophthalmos and moon phases. As I told you, Cushingoid phases. Cushingoid phases is actually, you will get these things in the face. The hairs will be thinned, there will be hirsutism. Hirsutism means male pattern of hair in the females. Acne, plethora, psychosis, cataract, mild exophthalmos and moon phases. Peptic ulcer may also occur. Hyperglycemia, centripetal obesity, menstrual disturbance, stria, that is marks on the abdomen, and hypertension. These are important features. Exuberant callus with fractures, decreased skin thickness, bruising, tendency to infections with poor wound healing, and little inflammatory response. Osteoporosis may also occur, and wasting and weakness of proximal muscles of the thigh is also a feature. Now you see this picture from top to bottom. See, this is the emotional disturbance, moon phases, see the face, osteoporosis, cardiac hypertrophy due to from hypertension, buffalo hump, this is the hump, buffalo hump, obesity. These are the main features. Thin wrinkled skin, abdominal stria, this is the abdominal stria, amenorrhea, muscle weakness, skin ulcers, poor wound healing, all of these are features of Cushing's. Now, how do you investigate a Cushing syndrome? First challenge is to diagnose from the clinical history, and the most important part is the features are non-specific. It's failure to suppress serum cortisol with low doses of oral dexamethasone. This is one method. Loss of normal circadian rhythm of cortisol with inappropriately elevated late night serum or salivary cortisol, and increased 24 hours urinary free cortisol. These are the three methods by which you can establish a Cushing syndrome. Now the most important is also very important for you to come as a short note. There is a dexamethasone suppression test. ONDST, what does it mean? Overnight dexamethasone suppression test. It involves administration of 1 milligram of dexamethasone at 23 hours, and serum cortisol should be measured at 9 hours the following day. In low dose dexamethasone suppression test, that is LDDST, the serum cortisol is measured following administration of 0.5 milligram dexamethasone 4 times daily for 48 hours. For either tests, that is ONDST and LDDST, the normal response is serum cortisol less than 50 nanomoles per liter. This is important. Now next is determining the cause. What is the cause of this? Plasma ACTH measurement is the key. It is measured in the morning at around 9 hours. In the presence of excess cortisol secretion and undetectable ACTH, that is less than 1.1 picomoles per liter, indicates an adrenal cause, while ACTH levels more than 3.3 picomoles per liter can suggest a pituitary cause or ectopic ACTH syndrome. Maybe a pituitary cause or maybe an ectopic ACTH syndrome. MRI is important. It detects around 60% of the pituitary microadenomas secreting the ACTH. And this is a very important test, but it is only performed in expert centers. It is not available everywhere. Bilateral inferior petrosal sinus sampling with ACTH measurement, it is the best means of confirming Cushing's disease unless MRI shows a tumor bigger than 6 millimeters, in which case it may not be needed. CT or MRI detects most adrenal tumors. So in case of difficulty, you can do bilateral inferior petrosal sinus sampling. It's a very important test, but performed in less number of centers. Now the management. Management of Cushing's disease. Transsphenoidal surgery by an experienced surgeon with selective adenoma removal is the treatment of choice. This is important. It should be done by an experienced surgeon and in centers where it is frequently done. 70% undergo immediate remission, while 20% suffer a recurrence a year later. In those patients, lifelong follow-up is required. Laparoscopic bilateral adrenalectomy effectively cures ACTH-dependent Cushing's syndrome. And regarding the medical management, there is a somatostatin analog, pasireotide. It is used for the treatment of Cushing's disease, and it suppresses ACTH secretion by the tumor. Regarding the adrenal tumors, laparoscopic adrenal surgery is the treatment of choice, and radiotherapy to the tumor bed reduces the risk of recurrence. And ectopic ACTH syndrome, it is actually very difficult to treat this syndrome, because what is important is to find out the cause of the syndrome. In small cell lung carcinoma, the patients are in advanced stage, it is difficult to treat, and the life expectancy is also very less. But in localized tumors such as bronchial carcinoid, these tumors should be removed surgically. What is most important is the cause of the syndrome. If it is a benign cause, the cause should be treated. But in malignant causes, it's very difficult. Thank you.